I might actually sit over there.
So we have three things we would like to do today. We have an award from the United States Public Health Service that we would like to make initially. And I would like to do a brief introduction of our Take Wing Award winner, Dr. Kathy Spong. And Dr. Spong is going to give us a wonderful presentation. So without any further ado, Ms. Algonquin, please.
I believe Bridget was grabbing one more thing. Bridget was. Okay, great. Hi, good afternoon. All right, good afternoon, UMKC. I am Lieutenant Commander Catherine Olguin. I am a registered nurse, a nurse officer for the United States Public Health Service Commissioned Corps. We work under the Surgeon General. And, excuse me. We serve on the front lines in the nation's fight against disease and poor health. Our uniformed services was founded in thank you, excuse me. Okay, our uniformed services was founded in 1798 to provide medical care to sailors and merchant seamen who suffered from yellow fever and malaria. And over the subsequent 225 years, our mission has broadened to deliver health promotion and disease prevention to all people. I am here today on behalf of the Public Health Service Physician Professional Advisory Committee to recognize an outstanding medical student who has been selected to receive the 2024 Excellence in Public Health Award. This award was established to recognize medical students' contributions to the commitment and contributions to public health. In recognition for their demonstration and dedication to public health, it is my pleasure to now present the 2024 United States Public Health Service Excellence in Public Health Award to Rohan Chakrabarty. There you go. Thank you. Rohan, your leadership in planning efforts and hard work truly demonstrate your passion and dedication to meeting the public health needs of others. Your actions at Care Beyond the Boulevard and 0 to 60 have focused on eliminating disparities to support health promotion. I encourage you to continue your passion in medical health and public health, to be a leader in the profession, and most importantly, lead with integrity, service, and excellence. Once again, congratulations on your noteworthy achievement. We thank you, your community thanks you, for all your hard work and dedication to public health. We sure hope you consider a medical career with the United States Public Health Service. Thank you, sir. Thank you.
I am honored today to introduce our Take Wing speaker and award winner today. The award was initiated in 1988, and Dr. Spong is the 36th recipient in the school's 53-year history. She is emblematic of the best and brightest of us. Dr. Spong is professor and chair of the Department of Obstetrics and Gynecology at UT Southwestern Medical Center. She completed her residency at Harbor UCLA Medical Center and served as a maternal fetal medicine fellow at Georgetown University and the Eunice Kennedy Shriver National Institute of Child Health and Human Development of the National Institutes of Health. She joined the NIH for 23 years and served as clinical associate and senior staff fellow, deputy director, acting director, associate director for extramural research, and chief of the pregnancy and perinatology branch. She served on multiple committees and task forces. Her research has been transformational, and it spans neuroprotection, fetal surgery, prematurity, improving child outcomes, and many other essential issues dealing with maternal fetal medicine. She was appointed chair of the Department of OBGYN at UT Southwestern in 2021, and her research productivity and contributions have been remarkable. She has over 550 research works to her credit. She has been cited over 32,000 times. She co-authors and edits the leading textbooks in the field, And she is also a member of the National Academy of Medicine, which is among the greatest honors in all of medicine. We salute and honor Dr. Spong, who is a source of exceptional pride to us as a compassionate and brilliant physician scientist who has had a profound and positive transformational influence on mothers and children across the world. But I'd like to add a little bit of color commentary, if I may. The Take Wing Award was named by Dr. Dimond, our beloved founder, the person who created our medical school, who thought of this novel and innovative 6-year approach with continuous learning, a lot of clinical medicine, ennobling individuals who come out of high school. It's named after a sculptor. He was a sculptor, and he was walking on the beach in California, and he saw a piece of driftwood. And in that piece of driftwood, he visualized this shape, a wing. Anyone else would have just seen a piece of driftwood. He saw a wing. He saw a soaring wing, something aspirational. And in all of us who are graduates of this school, he saw in 17 and 18-year-old high school students the potential to be transformational leaders in OBGYN, affecting positively students, teachers, mothers, children across the world. And that's why Kathy deserves the Take Wing Award, because she is emblematic of what Dr. Dimond was hoping to do with our school. This is for you.
Thank you so much. Can you hear me? Yes. Fantastic. What an honor to be here to receive this award, which is really the biggest thing UMKC can give you. I am just so very, very honored. I include Dr. Dimond's picture because I agree with Dr. Norbash that, without him, we wouldn't be here. And I loved coming to UMKC. And I know people used to say to me, well, you missed your summers. You missed the undergraduate experience. I didn't want my summers. I wanted to be here at UMKC and to really start my journey and figure out, is this really what I wanted to do? So I thank him. I thank Dean Jackson for the award nomination and for believing in me and for having me here. I thank Dr. Norbash for the incredible words and for bestowing this great honor on me. And Dev Malik, who was a mentor for me many, many years, and not only here, then he went to New York, and in New York, he had me as a fellow come up and give grand rounds. And I learned then how to do that because people who believed in me had me come and visit and give talks. And I want to thank you for your service in the public health service. I actually was in the public health service when I was at the NIH, so we have a little connection there. So let me tell you a little bit about the importance of inclusion, research, and lessons learned. And hopefully there'll be something in this for everyone. I really am excited about the part of inclusion as a carry forward from yesterday, where Dana Thompson talked a lot about inclusion as well. And so I think it was kind of neat. Dana and I were classmates, and we spent the entire afternoon yesterday catching up over 33 years of time missed. I don't have any conflicts related to this presentation. That's a picture from my backyard in April. We were in the path of the total solar eclipse. And if you stand under a tree, when it's happening, you can see the crescent shapes. And so those are the crescent shapes, which was really fun. What I want to do is talk first about the importance of research, talk about the importance of inclusion, the importance of research, and then some lessons learned. So that's going to be a little bit about me. Born in St. Louis. I know there's other St. Louisans here in the audience. My parents are an engineer and a biologist. My sister is older than me. She's the smart one. I'm the one who's persistent. And I love Emo's Pizza. I know a lot of people who don't come from St. Louis do not love Emo's Pizza, but there's nothing better than having your mouth stuck together with that Provel cheese. Everyone agrees that Ted Drew's is amazing. I love Ted Drew's as well, and loved being from St. Louis, but my parents did move away from St. Louis right when I started medical school. So my journey from UMKC took me to Harbor UCLA after I did a sub-I as a 6th-year student or 5th-year student and delivered 70 babies and did 3 C-sections in that 1 month, which was incredibly cool as a student to be able to do that. Then I went to Georgetown and the NIH for about 23 years, and currently I'm at UT Southwestern. So let's talk a little bit about inclusion. And why does inclusion matter? What do we care? Why should we include people? Why should we think, why spend time talking about this? Well, as I like to think about it, right, if you've got someone who comes in to see you and you identify a condition in them, you'd like to be able to provide a treatment that has an evidence base for it, right? And as the patient, you'd like to be given something that has some evidence to it. And then you get health, right? Well, there's a whole bunch of people that are not included in any research. So my inclusion is going to focus mainly on research for this component of the talk, because I'm kind of pulling those together. But I just ask you to think to yourself, if groups of people are not included in research, there's no data generated for them. And then treatment, sad to say, is based on educational guesses, right? What do we think is a good idea? Ideally, you'd really like precision medicine, right? Where you know exactly for that person what you should do. But that requires people to be included in the project to begin with. So this is a paper that I published, I think, about 2018. And I was really interested in this topic of inclusion in research. And first, to think about it, okay, who is not typically included in research? And would you believe that it's 59% of the US population who is not, that's the majority, just for those who don't remember the math, it's over 50%. So you can see that up to 59% of the US population is comprised of people who are typically not included in research. Pregnant women, children, older people, those with intellectual and physical disabilities. And yet, we treat them, we see them, and we care for them. So I went on to look at a bunch of NIH-funded trials. Yes, I was at the NIH at the time, and I decided to jump on my own institutions. We looked at open phase 3 and 4 clinical trials. And explicit exclusion was for 68% of pregnant women, 47% of lactating women, 75% of children, almost 28% of older people, 12% of those with intellectual and physical disabilities. That's just terrible. None of those research studies, right, are including populations that affect over half of the US population. Oops. So are we comfortable with that? I just want to pause for a second. Think to yourself, are you comfortable that up to 59% of the US population are not studied and are not included in research, and yet we care for them every day, and we want to do our very best to help them? This is why inclusion is important. In the US, there's over 6 million women who become pregnant. Over 90% of women, when they are pregnant, take some form of medication. And I can tell you, there's not a lot of evidence for that medication that they're taking. Almost 500,000 women annually have difficulty making milk, and yet there's the desire to breastfeed, and there's a difficulty, and so then they take medications to try to help them have milk. And I will admit, pregnancy and lactation goes another complete level, because of course, if you study someone who is pregnant, it may not be the same across all of pregnancy, right? Your blood volume doubles. The circulating binding proteins for all of those medications that Dr. Cuddy and Dr. Foxworth taught me about, that changes, right? Your GI transit time goes down, so the concentrations are going to change. Your renal function changes. So across pregnancy, you've got to do serial studies. In addition, of course, the baby and the placenta change too. So the implications of taking a medication across pregnancy are different. So it's complicated, I get it, but we can do this. We can do this. We aren't the first ones, I'm not the first one to talk about the importance of inclusion. In 1985, Health and Human Services, HHS, put out a report on women's health issues. There have been a lot of different committees. Institute of Medicine has weighed in on this, and a lot of different wave initiatives, first wave, second wave. And then the Cures Act in 2016, 17, included a task force that would be an HHS task force focusing on how do we include pregnant and lactating women in research? And I had the absolute fortune of chairing that task force. As part of that task force, we looked at the state of research on pregnancy and lactation. We looked at everything. What do we know? What don't we know? What studies have been done? What studies haven't been done? What are we using? And I'm just going to walk through a couple of them. I promise it's not much. But this is looking at asthma. So asthma affects about 8% of pregnant women. Look at the paucity of studies in asthma in both pregnancy and in lactation. There's 4 randomized controlled trials in asthma in pregnancy. There's none in lactation. Yet, is anyone not going to treat an asthma attack in a pregnant woman? No, we're going to do it. We just don't exactly know how best to do it. How about nausea and vomiting, a condition specific to pregnancy, right? So asthma is like everyone's got it, right? This is specific to pregnancy. Can we have some people do some studies and come up with some medications for this condition that can be absolutely debilitating? It occurs about 3% of pregnancies, and unfortunately, so few studies. The most publications are review articles. That's kind of a statement. That's really sad. Like, best evidence, best is based on a review of what other people have thought. Low milk supply, again, huge issue. I have 4 children. I wanted to breastfeed all of them. My first one, it was harder than others, and it's like, what can I take to augment milk? Look at the paucity of studies. Again, reviews are the majority of things here. Incredibly small studies, very little information, but yet such an important thing if someone wants to breastfeed their child to be able to do it and have an adequate milk supply. We also looked at how many studies and what's the funding for the different studies in pregnancy, in maternal health, and in breastfeeding. And just to say, it's really, really small compared to other areas at the NIH. For pregnancy, it's 0.2% of NIH funding is on pregnancy studies. That's about equal to that of pneumonia and influenza, and just slightly higher than prostate cancer, right? Orders of magnitude for many, many other conditions. So I convened this task force for HHS that included people across all of government, industry, private citizens, to try to say, how can we improve pregnancy research in pregnancy and in lactating women? And we had a series of, 5, 6, 7 workshops, and then came together to come up with recommendations. We came up with 15 recommendations and wrote this whole thing up, and you can download it. Don't hit print. It will take about 300 pages. And came 15 recommendations. And the first recommendation, and the easiest recommendation that we could do, is use the default of inclusion, right? If you're doing a study, include people. Right now, the default is do not include a pregnant person. But you really should include the pregnant people and the lactating people. NIH policies require certain subgroups, and they require you to justify why you're not including women. The Pediatric Research Equity Act back in 2003 authorized the FDA to require pharmaceutical companies to include children in their new drug applications. But we don't have this for pregnant women and for lactating women. In fact, in 2019, after the task force, the NIH did do one change. They changed to require not only do you have to explain why women are not included in research, you also have to include why children are not included and why the elderly are not included. But again, silence on pregnant and lactating people. But it's good, we're moving forward. We've got a couple additional groups that are now, you have to at least justify it. So it'd been several years, and one of my medical students said, I've got some scholarly activity time coming up. Do you have anything you want me to do? And I was like, well, we were talking about different things, and I said, well, why don't you repeat that study that I did in 2018? Because now it's multiple years later. Has this done anything? And so Lisa went to work, and I'm sad to say that, in fact, no, we did not move the bar at all. She looked at the same search parameter just that many years later. Actually, more studies are excluding lactating women. And across all groups, really no improvement pre or post recommendations. So I just want you to think a little bit about, are we comfortable with this? Are we comfortable for your child, for your grandparent, for pregnant and lactating people in your life, for people with disabilities, not to know what is the actual dosing, what is the actual medication we should use. To do this is going to require buy-in from a bunch of groups. The scientific community has to think it's important, right? Pharmaceutical companies are going to have to think it's important. And that gets into really tough issues about liability. We need money to do these studies, right? And if you want the NIH to fund these studies, they're not going to be funding something else, and that person's going to be mad. And then we need to educate everyone on why this is important. This is just a slide from my now 16-year-old daughter's science fair project that she did in 2021, looking at COVID vaccines. And so this was right when the vaccines were all being studied. And I said, okay, let's see how many of them include pregnant and lactating people, because they get sick with COVID. So she looked at all of this. There are 90 trials in clinicaltrials.gov. Each one's represented by a row. You can see all the 90 in the right-hand side. And if it's red, it means they're not included. And you can see that there are subgroups that are not included in all of them. And pregnancy and lactation were excluded by most. And yet then that left us with a conundrum of, do we vaccinate pregnant and lactating women? And people say, oh, well, gosh, we don't want to do that. You know, that might cause harm. But not doing it can cause harm too. So I like to think about this as protecting through research, not protecting them from research, which is essentially what we're doing right now. Okay, so let's shift a little bit. This is just a quick PubMed of obstetrics. And you can see one of the reasons I went into OB is I love research. I'm the persistent one, my sister's the smart one, but I can see something through. And I knew that there was such little data that I would never run out of things to do, because there's always going to be a study that I can do. So you can see there's research picks up a little bit in 1988 and again in about 2014. So these are all studies, clinical trials, some observational studies, predominantly clinical trials, that I participated in and am an author on from the NIH when I was running the Maternal Fetal Medicine Units Network, which is a network of about 16 sites across the country doing studies in pregnancy. And so what I want to show you on this is that all of these studies, which ranged from a couple hundred women to 10,000 women, included pregnant women. So do you think pregnant women are willing to be in studies? Absolutely. They want the evidence. When you explain to them, we don't know what's best, they want that. And then what's even more astonishing to me is how many of those stopped a practice. Meaning we thought something was good. We thought giving you this medication would help you. And you know what? It didn't. So we're exposing the woman to something that she doesn't need. But we never had done the studies, and it seemed like a darn good idea at the time. Sometimes we identified a new therapy or a preventative therapy. Fantastic. But equally important is not doing something that we don't need to do. And the cool thing that, to me, is not only to do the study and to get the study published, and super cool when it gets into a big textbook, super cool, but to get it into the clinical guidelines of your specialty, right? So working with the American College of OB-GYN for me, or the Society for Maternal Fetal Medicine for me, getting this stuff into that guidance so that everyone then knows what evidence do we have and what evidence don't we have. So I'm going to go through two brief trials just to give you an example of this. So these were called the BV and TV trials. BV is for bacterial vaginosis. TV is for Trichomonas vaginalis. Two conditions that women can have. They're vaginal conditions. And it was clear that if you were high risk, if you were symptomatic, and you had bacterial vaginosis, and we treated it, we could reduce the risk of preterm birth. Now, it's an incredibly common condition. And the thought was, well, lots of people have this. Maybe we should be treating everyone for this, right? Maybe we should screen everyone and treat everyone. So we did two parallel randomized controlled trials in the network looking at whether treating them would reduce the risk of preterm birth in asymptomatic women. So this is just asymptomatic. They don't even know they have it, right? It was a double-masked placebo-controlled trial across 16 sites in the US. They were less than 24 weeks, positive for either one of the two conditions. They were given the medication or given an identical placebo, right? Perfect way to do this. Primary outcome is delivery at less than 37 weeks. Seems to make sense, right? And we've got a preterm birth issue, so let's see, maybe we can fix it, nix it in the bud. So this is looking at asymptomatic bacterial vaginosis. Those who got the medication are in blue, those who got the placebo are in brown. And I think we can all agree, we did not prevent preterm birth, right? More alarming is the Trichomonas vaginalis, the little trichomonas that's like swimming around in there. If you get rid of that, you increase your risk of preterm birth. Crazy. Now we know with the microbiome, right, whatever grew back was worse. So if someone's asymptomatic, don't treat them. Don't go looking for something that you don't need to look for. Counter to our initial thought, but really, really important. So we did look at test of cures. Did people actually take it? And yes, 80 to 90% were negative on their test of cure. But treatment of asymptomatic BV doesn't reduce preterm birth, and treatment of asymptomatic trichomonas actually increased your rate of preterm birth. And this then got put into all of the practice guidance. And at that point in time, it was really a time when people didn't mind giving antibiotics for a lot of things, right? Because, oh, well, she's uncomfortable, let's give an antibiotic. This kind of squashed that and said, don't just give antibiotics randomly. The second study I want to talk about was the management of myelomeningocele study, probably one of the most difficult. Come on in, we got lots of room. Come on in. One of the most difficult studies I've ever been involved in. I was the program scientist for this. It was the first fetal surgery trial done on a non-lethal condition. So myelomeningocele or spina bifida, babies survive, they deliver, you repair it, go on. And there was recommendations and guidance from some animal studies to say, if you repair it earlier, you can improve outcomes. And the thought is by repairing it earlier, you can allow the brain to develop more normally because you can get rid of that hindbrain herniation. So we did a randomized controlled trial, believe it or not, of fetal surgery. It was not blinded. We did not do a sham surgery on the patients who randomized to postnatal repair. But the evaluation was by blinded independent investigators, meaning they didn't know what happened to the baby during pregnancy or after delivery. They didn't know if fetal surgery was done. And what we found was that prenatal surgery had great improvements in outcomes for the kids. It reduced the need for a shunt. Over 90% of these kids need a VP shunt. It reduced death and improved motor outcomes, double the number of kids who could walk independently at 30 months. That's great, right? That said, there was a significant increase in preterm birth, and perhaps more importantly to me, huge implications for the mom for a subsequent pregnancy. And so often we as OBs are looking just at this pregnancy and what are we going to do for it, but we also have to have in mind what's going to happen in the future. Because when they looked at patients after that pregnancy, the next pregnancy, they had a uterine rupture in over 10%, which is catastrophic. So if someone wants to have multiple pregnancies afterwards, it's probably not the best idea. Again, incorporated into the guidance. So I hope you walk away from this saying to yourself, pregnant women, lactating women, are happy to participate in research. They really are. And I'll get into this in a minute, they want to know and to create that evidence. Creating that data provides us the ability to give evidence-based therapies and gives us the ability to come up with what recommendations we have. A couple of studies have looked at why do women want to participate in research. They want to understand the condition that they have. They want to know what treatment do I need. They're actually pretty much appalled that we don't have evidence to show them. They want to create the evidence for practice, for their friends, for their children. A lot of interest in moving science forward. Just how can we do this? They want to receive the latest and greatest treatment, although I will say there were a couple of patients in the myelomeningocele trial who really didn't want the surgery, but they wanted to participate in it. too bad, you're going to get what you're randomized to. But, and they wanted the additional care and attention from research staff. So really important to understand that pregnant and lactating women are more than happy to participate in research. Okay, I want to pivot and talk a little bit about lessons that I have learned over my career. And I talked a little bit about this already with some of our students earlier, so I apologize that you guys have heard some of this. But the first is to find the opportunity. So sometimes the opportunity is a paper on a bulletin board, right? Sometimes it's a pandemic, okay? So one of my faculty members loves infectious disease. And she had heard about what was going on with COVID, threw an IRB in, and started collecting the data that you see here of all of our COVID cases in labor and delivery. You cannot deliver a baby virtually, okay? So we were in there every day. Our service never stopped. Other people said to me, oh my gosh, did you see, like I'd never seen the lighting in my living room on that, at that hour of day because I was at work. I'm like, no, I was still at work. And she was able to parlay that into a number of great publications looking at pregnancy outcomes in women with and without COVID. All of the data before this paper was from the Northeast, which was hit first and hit hard, but it was all in patients who were hospitalized. And we could look at patients who were, yes, you have COVID, but you can go home, right? So if you look at only the hospitalized patients, yes, it's absolutely terrible. But pregnant women actually experienced COVID similar to everyone who experienced COVID. Some had it really bad and some did not. Okay, so we can study COVID, but we can also study how we changed care. Because I assume you all, similar to us, pivoted heavily to virtual care. Now in pregnancy, we would never do prenatal care virtually. That is just not something we do. Well, we did in COVID. And we were able to show on the right, Elaine Durier's paper, that it didn't hurt outcomes. And in the left paper of Denise Holcomb led, they liked it. They liked not having to come in and wait 3 hours in our clinic to be seen. And our virtual visits were not a video visit. We didn't have that technology. They were a phone call. And we could then take this paper and send it to the state and send it to the payers and say, reimbursement for phone call only should be done because look, the outcomes are the same and the patients prefer it. They like the phone call better than the virtual visual visit. Okay, lesson number 2. This is something that I am trying very hard to do. I've learned it later in life than I probably should have. So I want you all to learn it earlier than I did. My husband does call sometimes what I say Kathy speak, like, what is she trying to say? And sometimes on rounds when I ask the residents a question, right, I say, tell me what's in my mind, because I can't quite get out exactly what I'm trying to ask. I'll ask a question and then I'm like, yeah, just read my mind. Okay, so that's not fair, and I know it. So I want to take you through a very simple example that I did about this so you understand what I'm saying. So this is a text that I send. Now understand, I am chair, and I'm sending it to my faculty member. Are you still at Parkland this morning, or have you already headed out? I think you're post-call. Okay, it's like 10 o'clock in the morning. Here I'm saying, are you here? What's the attending going to say? I'm still around if you need me, right? So what do I say? Where are you? I'm on the 7th floor, just finished antepartum rounds. I'm now at the elevator coming to you. She texts back, I'm like 20 minutes away from Parkland. I'm picking up coffee. Would you like some? No, stay home. I have your Tupperware. Are you going to be here tomorrow? Right? She then says, can I call you? You've got me scared. What I should have said, I have your Tupperware. Are you still here? Right? Explain why you're asking the question. Because people will have all kinds of things in their head of what they think you're asking the question about. and it's not fair to them. And to be fair, 2 days before, we had a code on labor and delivery, right? So she knows, like, anything can happen. 20 minutes away, I'll be right there, whatever you need. No, I have your Tupperware. So I encourage you, learn it earlier than I've done, do it better than I do, don't do Kathy speak, communicate with intent. Lesson number 3, this is really important. Your job is not your life, and nor should it be. Anyone can do my job, whether it was deputy director, acting director, running a network of studies, publishing studies. Anyone can do that, and trust me, they will. I walk away, they're gonna do it. Someone's gonna do it. Only I can be a daughter, only I can be a mother, and only I can be a wife. And so, incredibly important for you to recognize that family is everything. I'll put friends in there too. Incorporate your family into everything that you do. I did a lot of traveling when I worked at the NIH, going site visits, talks, presentations, and I would work to bring one of my children with me. And I would fly out my mother-in-law, or my parents would fly out. They would stay with me. They'd get to be with the kids. I'd still get to be with some kids. And it was a great way for them to get to see the kids. So yes, it took some coordination, but something that I strongly encourage you to do. I will say that one time I was here in Kansas City, and I brought one of my children. My mother-in-law lives here. And the other kid had missed a bunch of school, and so my husband, Barry, he said, no, Genevieve can't come because she really needs to work on what she's doing. I came home to a cat. So somehow Genevieve convinced my husband that because she didn't get to go, she should leave school early and go to the animal shelter and get a cat. So maybe bring them both rather than just bringing one. Lesson number 4, and we talked about this already, so sorry for those who've heard this, is leverage the opportunities. And I want to give a couple of examples of how I did this. And this is really what I did as a student and mainly as a resident to try to come up with research ideas. And I encourage those practicing medicine to do this every day. Just think about what you do every day. Why do you do that? How do you do that? And is there any evidence behind it? In OBGYN, there's never evidence behind it. Well, maybe sometimes now. So let me give an example. This is an example of amnioinfusion. Amnioinfusion is when we put fluid back into the uterus during labor because you get these things called variable deceleration. So the thing on the top line is the baby's heart rate, and those V's that you see, that's the baby's heart rate going down. You don't like that. The bottom line up there is uterine activity or contractions. And so you can see that there's these variable decelerations. And so we do this thing called amnioinfusion, and sometimes the variables go away, and sometimes they don't. So I'm doing this, and then I'm saying to myself, why? What is the evidence? Why does this work? So I decided, and I was on call every other to every third night, so I was there a lot to be able to collect data, that I would try and understand this and explain why sometimes it worked and sometimes it didn't. And you're going to be like, this is so obvious. But we didn't have the data, and it was a nice paper, and now it's in a textbook, so it was cool. So what I did was I looked at how much fluid is in the uterus before I start the amnioinfusion. And then I blinded, looked at all the tracings to say, did the tracing get better? And I had specific criteria for how to do that. And what I found was that so on the x-axis is the amount of fluid, the AFI, amniotic fluid index, and on the y-axis is the incidence or percent. And that solid line shows the success of the amnioinfusion. So it's super helpful when you've got no fluid. It is not helpful when you've got a ton of fluid in there. This makes sense, but we didn't have that data. And a tight nuchal cord, or a knot in the cord where the cord is wrapped around the baby's neck, is super high when you've got a lot of fluid. So what does this allow you to do? To check the amount of fluid before you start the amnioinfusion to say, is this going to help or not? And then you don't expose someone to a procedure that they don't need. A second example was, again, I was on call a lot, delivering a lot of babies. And shoulder dystocia is a condition where the baby gets stuck. It's a terrifying condition in obstetrics because heart rate is going down, down, down. The head is out partially, and you can't get the rest of the baby out because the shoulders are stuck. An absolute obstetric emergency. The definition is terrible. The definition is if you used a maneuver to help get the kid out, which sometimes is well documented, sometimes not. Sometimes you do a maneuver, the kid comes out pretty easy. That wasn't a shoulder dystocia. So I wanted to come up with an objective definition of shoulder dystocia. So I went in and delivered and timed all of these deliveries, from delivery of the head to delivery of the body, and came up with a time, the average time plus 2 standard deviations, 60 seconds. If it takes more than 60 seconds to deliver the baby, you've had a shoulder dystocia. And that then led to a whole series of studies looking at what if you do a prophylactic maneuver, can you reduce things? Which maneuver is the best one to do? How much pressure is being put on? So super cool, but it started with the question of how am I calling a shoulder dystocia? What is the evidence behind it? Let's create that evidence, and now using that, we can do other things. I'm going to end this component of the talk on anemia. So anemia is defined in pregnancy by 70 Scandinavian women in the 1970s. That is the study that is published and cited, 70 women who are Scandinavian. So I said, is that really appropriate in this day and age? So we did a study. One of our fellows did a study, Amanda Zofke, and she took 1,000 women at Parkland and who didn't have high blood pressure, didn't have diabetes, didn't have anything, and said, what is the less than 5th centile for anemia across pregnancy? Come up with these beautiful curves. And I will tell you, we were resoundingly rejected because they said, it's a lower socioeconomic, 90% Hispanic population. That doesn't represent the US. I'm like, well, 70 Scandinavian women didn't either, but okay. So we then went to our university hospital, totally different demographic, another 1,000 women. And we were able to come up with what is the definition of anemia. And you know what? It's essentially the same. So that was cool. We've defined anemia in our population. It got published in PLOS One, great paper. Whoops, I went backwards. And we said, okay, well, we got a lot of anemic women. What are we going to do about that? And Lisa Teely, who was my medical student who did that inclusion thing, she's like, you know, hey, I'm ready to do some more. So we looked at a study where we handed women prenatal vitamins. We didn't just say, here's a prescription for them. We didn't just say, go and buy them over the counter, which sometimes we do. We handed them a bottle of iron. It had iron and folate in it. And to be fair, you know, we deliver 14,000 babies a year, which is 2 kindergarten classes a day. Something that happens 1% of the time. We see it every 3 days. So we had to go and get a company to make this Folavane, this component of iron and folate, for us because you couldn't just buy it. So we handed out, so we first looked at before pre-Folavane, and then we started handing it out. And we compared 2 time points, a time point without Folavane and a time point after women would have started the Folavane in the first trimester and been able to have it throughout pregnancy. Over 20,000 bottles of Folavane were distributed, which means that they had enough to get them through their entire pregnancy. And they would get a bottle of 90, and then they'd come back and get another bottle of 90, and then another bottle of 90. What we found was that we were able to reduce the anemia rate in this patient population. Post-Folavane is the ones in blue, and pre-Folavane are in the gray bars. So we could reduce anemia, and to me, most importantly, we could reduce anemia at the time of delivery. We reduced postpartum blood transfusion for symptomatic anemia. So the lady who came in low, and then 2 days out, she's lower, and she's symptomatic, and we have to give her some blood. They come in higher, they're still lower later, but they don't need blood. And we were able to really shift that curve for the hemoglobin and hematocrit. The second thing I want you to think about as you leverage opportunities is borrowing what other people are doing. Because for us in OB, everyone else is way smarter than us. Everyone else is more advanced than us. So what is cardiology doing? What is radiology doing? What are the new techniques that groups are doing? take their advances and think to yourself, what can we do in OB? And what that means is you've got to read outside your field. You can't only read what's in your field. And just as an example of that, when I launched the Human Placenta Project at the NIH, it was kind of sort of crazy. Like, why would you do this? The placenta is, you can't touch the placenta. You can't biopsy it. How are you going to study it across pregnancy? Well, about 5 years earlier, the NIH had launched the Brain Initiative. You're not going to be biopsying the brain either, right? But they're looking at cellular level detail of the brain. So let's leverage the technologies that they're using in the Brain Initiative on the human placenta. Lesson 5. I promise there's not too many more. As a leader, what you talk about matters. And it is always a little bit hard to me to recognize that I am not still a medical student, and that when I say something, it carries a different weight. I have your Tupperware, right? I'll be right there. And so as a leader, try to take my department forward, I've got to, if I don't talk about research, then research isn't important, right? So I try always to be inclusive. We're going back to that inclusion. Talk about the clinical work, because most important is excellent clinical outcomes. Talk about the great educational work, because we train 1 out of every 70 OB-GYNs in the country. And talk about the great research and the evidence that we are creating. And it's because of that that we now have an $18 million PCORI grant, because it's important to do research. And we empowered, and I worked with our faculty to put in that application. We have K awardees. We have people doing amazing things. Okay, my thoughts for you. Explore the opportunities that present themselves, as well as seek interesting opportunities. And I know Dana yesterday in her talk talked a little bit about, she just cold called people to say, I'm interested in doing this. Can you help me? You went to UMKC, I'm going to UMKC, can you help me? So seek opportunities, but also if there's something on the bulletin board that's of interest to you, take that. Never dismiss an opportunity. Ask questions about it. Push yourself to always do your best. That is so important. It's never something where you can say, you know what, it's 5 o'clock, I'm done. It doesn't really matter. I don't need to answer that question. Why are they coming to? No, it's important. Patient care comes first. All careers benefit from strong writing, communication, communicate with intent, and critical thinking. Find the things you are passionate about and pursue them. And I added one more that I think is especially important. And that is that you accept that you are imperfectly perfect. Sometimes things don't work out. That is okay. Don't beat yourself up. I've done that more than I ever needed to, and it never helps. Don't beat yourself up. Just keep moving forward. My goal as chair is clinical excellence. I want outstanding care for my patients. I want educational excellence. I want to teach the next generation. I want research advances. I want and I love creating the evidence for practice. And I want my faculty to develop. I want them to be promoted. I am a promoter of my faculty. There is not an award that comes across my desk that I can nominate someone for that I don't put someone's name in. And celebrate and elevate your faculty. Inclusion and research are absolutely vital to these goals. So hopefully you're taking away from this why inclusion is important, why research is important, and what lessons learned. Maybe you took one of those home. So I appreciate your attention. I am happy to answer any questions and hear your perspectives. This is what we saw with the solar eclipse. It was really cool. I didn't totally understand what we were going to see. My brother-in-law and sister came in, and we had a bunch of other friends over, and it was a really, really neat experience. So if you've not experienced a total solar eclipse, my understanding is in 2 years there'll be one in Greenland or Iceland. Maybe I will see you there. Questions? My apologies for making you all sit through this. You were here for this part, but thank you for being so patient. Yeah.
So you were talking about how the future is personalized medicine. So I feel like that's a whole area that it's almost unclear how to do research in a way where you're inclusive, but you're also trying to target specific groups.
Right, and it's gonna require a lot of data, right? So you're gonna need to have the research to be able to then parse it down into similar type groups to say, does this therapy work in that group better than in this group? And so maybe I wanna use this blood pressure medication instead of this blood pressure medication. But it's gonna require not only having people in those studies, but having a lot of people in those studies.
Another question is, what role do you think AI has in that sort of expansion into personalized medicine?
So AI is incredible and terrifying and amazing and absolutely terrifying. I think using AI, and we're doing this on trying to understand which patient is going to increase her risk for having placenta accreta spectrum, using AI to evaluate the textural density, et cetera, of the placenta. So I think that there is opportunity to use AI, but until we actually have all the data, we're not going to be able to use AI for the more simple medication type things. But it's a great question. Yeah.
I loved your talk. Thank you. I wanted to ask a question about inclusivity in research. Dr. Bridget Jones has studied this also, and as she studied asthma therapies for children who are most likely to die, what she found was children who were Black were not being included in studies, and they were at greatest risk for death. And so the work she's done has been really transformational. So in your study of pregnant women where you were inclusive, do you feel that you got an adequate look at pregnant women who represented different races and ethnicities?
Yeah, so that's always a question that you're trying to figure out, right? So what test groups do you want to, what groups do you want to study? What groups are most impacted? And then from that, how can you ensure that they are included in the studies? So some of the studies, some of the therapies are felt to be better in a certain group. So we want to oversample that group. And to do that, you have to have buy-in from that community. And you have to have people who understand how to explain that, you know, this is why we have equipoise, we don't know the right answer. And often having someone from that same background is incredibly helpful because they understand the culture and everything that goes into the person who's making that decision. But it is incredibly important. The PCORI that we're doing is looking at postpartum health and how to identify and treat complications earlier. Those complications are predominantly hypertension, infection, thrombotic disease. So we are oversampling people who had a C-section after choreo, right? Women with hypertension, so that we can have an enriched group.
Another question about inclusion. So especially for pregnant people in our current environment and states with various laws that impact the health of pregnant people, how do you think that's going to impact the ability to include pregnant people in research? And have you already seen some impacts of whether or not people want to be involved in research or not?
That's a great question, and I think it relates to what is it you're studying, and then is that impacted by the politics and the situation that is going on in that state? So I will say for us, we have not had an impact or a decrease in the amount of women interested in doing research with us. There was, interestingly, an increase in the amount of people doing research during COVID who would sign on to a research study during COVID. We think it was, and this is a study that we're doing of MRI in pregnancy, right? So you've got to convince someone that it's okay to get in an MRI machine when you're pregnant, which we do all the time when we're concerned about an anomaly. So we do this. During COVID, people signed up in droves. Harder now. It's harder now. And I don't know if that is because, you know, now they're working again. It's not such a novel thing to get out of the house. But yeah, no, it's a great question. Thank you. Yeah.
Thanks so much, Dr. Spong. My question for you has to do with your time at the NIH and when you kind of saw how decisions were made about funding. If you look at some of the biggest problems in terms of pregnancy, it's like preeclampsia, spontaneous preterm birth, preterm parturition. And those are probably going to be basic science answers. ish, that, like, what is the funding like for that? And do you think that that is gonna be something that might change in the next couple of years?
So a sad note to that is prior to, I think, 2018, there was no category for pregnancy at the NIH to look at funding. So you couldn't even say how much funding was done in pregnancy or in maternal health. There have been the areas you've described, preterm parturition, preeclampsia, et cetera, those are big numbers, right? And those are things that we need to address. And certainly, like in the network, we targeted that. We did the big vitamin C, vitamin E trial to see can you prevent preeclampsia. There's an ongoing study now in the network on trying to prevent preeclampsia. But it needs more funding, and it is not prioritized. That's a simple way to say it. It's just not prioritized. You have to have someone there pushing it, and then someone receptive to that push.
How do you ally with the IRB to help circumvent kind of those institutional problems?
Right, and being friends with your IRB and knowing what your IRB is willing to do and not do is really, really important. And we do that by having people on the IRB and going to educate the IRB. So one of the things that we are able to do, because it's such a high volume, is we can, everything, as you know, is protocolized, right? We're gonna do things in the same way because we want excellent outcomes for our patients. And in doing so, everyone's gonna get the same induction agent for their delivery. Now, there's lots of different induction agents out there. You can do it oral, you can give something orally, you can give something vaginally, you can give a different dose. And there's equipoise in that. They're used all over the place, all these different things. So we worked with our IRB to design studies where we randomized by week. I think you were there for some of these. And by randomizing by week, okay, this week you're gonna get oral medication, this week you're gonna get vaginal medication. You've then got the entire population. There's no opt-out from an RCT. You don't have any bias. It's a generalizable study. And it's a safe way to answer that question. But if we didn't have people on the IRB understanding that, we would never be able to do the studies. But sit on the IRB. Yeah.
Thank you for a great talk. You highlight that there's limited evidence with regards to practices for obstetrics. My question for you is with regards to like study designs, right? So like we know RCTs are the gold standard. For people who are interested in research, should we be trying to only focus on RCTs, or are other study designs for, we know RCTs are time, take a lot of time, take a lot of money to do. So what is your recommendation with regards to
Yeah, so RCTs are great, right? They are the gold standard. That said, they have limitations too, because there are patients who are not going to be in an RCT, so it's not as generalizable. I will say from what we've done, where we will just throw down a decision, where we say, okay, we're gonna treat postpartum pain different. And we've always done it this way. We're gonna tell people to take iron. We've always done it this way. And then we change the practice, and we do an ERAS thing where you count up the amount of opioids they got the previous day, right? A before or after of however much on either side you want. It is a generalizable thing, and we reduced by 90,000 pills the amount of opioids going into Dallas, right? So it doesn't have to be an RCT. RCTs are great, especially for things where someone may not have the greatest equipoise, but if you don't have the greatest equipoise, you shouldn't be doing the study.
Is that where you recommend things like PCORI, where it's comparative effectiveness? So if you have two good ideas but don't know which one's better, you can...
Yeah, so PCORI is a really interesting group. What I love about PCORI is that they want the interventions to be things that patients want and that are important to patients. And I remember when I was at the NIH and NHLBI had this big thing on sickle cell disease, and they were going after the genes and going after this and transplants and whatnot. And then they asked the patients what did they want, and the patients wanted pain control, right? So I like PCORI because it's actually something, what do they want? PCORI does like this comparative effectiveness thing where you're doing two different interventions. And what we're finding, and what we did for our study, was we did a run-in period so that we could truly get the baseline data and then compare the two things, because by just comparing the two things, it's hard to actually know, compared to baseline, which one is better. Because both of them may have an effect, and then you've got no baseline data.
In generating future clinical researchers, which item would you recommend be included in the curriculum, either in the medical school or in residency training to sort of enhance a student's knowledge of research? Would you say it's like every school should have a statistics course, or they should all have a required research project, or should everybody be trained how to do a meta-analysis? Well, what do you think would be the most important item that really every medical school should include to prepare our students and residents?
That is a great question, and I don't want anyone to be unhappy with me. That said, I will say there's no one thing. I think exposure to research and exposure to understanding that you can actually do it even if you are a student or a resident, and that there's mentorship and people around you, and to see the success of someone else doing it. I am not a fan of everyone must do a meta-analysis, everyone must do a research project. In fact, at our training program, we have 18 residents a year. So that's 72 residents in the program. That's a lot of research projects. And for someone who doesn't want to do research, it is torture for that person as well as for the faculty. And they're often doing something they don't care about, and then it never gets written up. So what I always want is to pick a topic that is important, but never don't publish the study. It needs to get published, so you guys see it all the way through. But I think honestly, it's just exposure. It's exposure to how fun research is and how it can make such a difference. I don't know that that answered your question, but. Yeah.
Comment, no question. One of the joys of my life, professional life, over a long period of time, one of the best decisions I took is to remain in the academic medicine. And why is that so? There are a lot of aggravations, a lot of disappointments, a lot of rules and regulations, a lot of people to answer, I am answerable to. But when I look at you and witnessing your journey from being a medical student, eager to do research, and look at you at this moment, it is not that your personal achievements, what you have achieved for women's health in this country. I'm extremely proud of you, and I congratulate myself. And amazing talent.
And I congratulate you as well, and I appreciate the OB department taking me on as a second-year med student. I mean, I was in the lab for actually the end of my first year through my 6th year, and it was great.
The term I use is the fire in the belly. You had that fire in the belly of doing research, finding new things to advance the science and practice of medicine. And this is just an amazing journey. It's very inspiring.
Oh, thank you.
Wonderful presentation also.
Thank you so much. Thank you so much. Thank you all for coming. I apologize. I never like to go over because your reviews are always worse if you go over. So my apologies, but I love the discussion and the dialogue, and that's the best thing ever. So thank you. Feel free to talk to me if you like, and congratulations. Was that okay?
Yeah, it was great. This is Shilpa. I don't know if you've met her.
Hey, great to see you.
Yeah, she's a yoga and pregnancy expert. She did a trial. She actually did a trial that was published in Very Journal. Well done. Yes. She's here now.